let me remind you again the valves we're talking about. Okay? So remember, we have in the heart, we have two upper chambers and two lower chambers. Okay? The upper chambers, these are considered receiving chambers. Right? So these are the atria. You have a right atrium and a left atrium. Okay? In the lower two chambers, you have ventricles. Ventricles are discharging chambers. The one that they send the blood away from the heart. Okay? Two upper receiving, two lower discharging. Okay? Now, between the two upper and the two lowers, you're going to have valves because as soon as the blood comes from the atria, from the upper chambers to the ventricles, you don't want that blood to go back or retrograde or regurgitate when you squeeze the ventricles. Make sense? That's why you have to have valves to ensure that the blood is going to go in one direction, outside, when you are sending it outside. Okay? These are very important, but we're going to concentrate on the left side. But they are both important. We concentrate on the left side because that's mostly the clinical stuff you're going to see. Okay? So the clinical pathologies are going to be stemming from the left side of the heart. So what do we have? On the right side of the heart, between the right atrium and the right ventricle, we have the tricuspid valve. Tricuspid valve. Basically, it's a valve that has three cusps or three leaves there. Okay? Tricuspid valve. On the left side, we have bicuspid valve, also known as the mitral valve. Okay? It's a valve that has only two leaves. Okay? Mitral valve. Because it's important, it earned its own name. Not only a bicuspid valve, but they have the mitral component. Okay? These are the two valves within the heart itself, between the superior chambers and the inferior chambers, upper and lower chambers. Okay? Aside from these two valves, you have valves in the big blood vessels. What are the two big blood vessels? We're talking about the pulmonary trunk. These are two arteries, pulmonary trunk and the aorta. Because when you discharge the blood from the ventricles and you dump it into the blood vessels, the pressure in the ventricles is going to drop. And it's fluid. Anytime, any fluid is going to go to the areas where you have low pressure. Okay? So when the pressure in the ventricles drops, what's going to happen? The blood is going to go back. And that's not good. Because this is the blood that's destined to go either to the lungs in the pulmonary circulation or to go to the other organ systems in the systemic circulation. Okay? To ensure that this blood is going to go in one direction and is not going to regurgitate, what we need to do, we need to have valves. And these are going to be your semi-lunar valves. Basically they are half moons, and that's why we call them semi-lunar, half moon valves. The semi-lunar valves. Semi-lunar valves. These are the semi-lunar valves. Semi-lunar valves. Where you find them? In just the very beginning of the aorta and the very beginning of the pulmonary trunk. Okay? And they're designed to prevent the blood from coming back. Now, the two pathologies that we're going to talk about when it comes to valves, there is only two. Either the valve being very narrow, very not allowing much for the blood to move on, and that's called stenosis. Talking about stenosis. Or the valve is not closing properly, and that's going to be incompetence. Okay? So these are only two pathologies. Either the valve is not closing properly, or the valve is very narrow. Okay? And in both cases, it's leaving blood not being sent to the destination where it should go. Okay? Now we are concentrating on the left side of the heart. That's why we're talking about mitral valve stenosis, mitral valves insufficiency or incompetence. Okay? The other valve we're going to talk about is the aorta. Aortic stenosis, aortic incompetence. So either stenotic or being not closing properly. Okay? And from here, you're going to see a wide range of manifestation of either stenosis or insufficiency. Okay? All right? Good? Yeah? So, if you want, I can show you all these valves, all these structures from the visible body. Otherwise, we can just use the osmosis to go over. I'm going to do aortic first. We're going to do aortic, but I'm going to stop it as we go. We're going to do the aortic valve diseases first, and then we'll do mitral. So again, we're talking about aortic valve disease. What are we talking about? We're talking about two pathologies, either being insufficient or being stenotic. Okay? These are the two conditions that we're talking about. Okay? All right. We're going to review again the type of murmurs you're going to see, the type of pathologies as a result of either the blood not being sent or regurgitating the blood back into the ventricles.
The aortic valve is typically made up of three leaflets, the left, the right, and the posterior leaflet. And it opens during systole to allow blood to be ejected to the body. During diastole, it closes to allow the heart to fill with blood and get ready for another systole. If the aortic valve doesn't open all the way, it gets harder to pump out to the body. And this is called aortic stenosis.
So you remember, so if it's stenotic, it's not opening properly and not letting the blood to go out. That means what's going to happen first, this part, this chambers, this left ventricle, it has to work very hard to be able to send the blood out. So eventually, if this can continue for a long time, you're going to end up having a tremendous amount of hypertrophy in this left side of the heart. Also remember, you're sending the blood out, so this blood has to go to other organ systems. Now, if I'm having difficulty sending the blood out, that means these organ systems are going to suffer. And the first organ that's going to suffer is the heart itself. Which is the heart itself. Because remember, again, when you review with you the coronary circulation, remember, right at the tip here, right at the neck, right here, that's where you have two coronary arteries exiting from the aorta. Okay? So these two arteries are waiting for the blood to be ejected from the left ventricle. And that's the blood that's going to be supplying the heart itself. If you have a difficulty sending the blood out from the heart, the first two arteries that are not going to get enough amount of blood are going to be the coronary artery. Coronary artery, right and left.
The body. During diastole, it closes to allow the heart to fill with blood and get ready for another systole. If the aortic valve doesn't open all the way, it gets harder to pump out to the body. And this is called aortic stenosis. If it doesn't close all the way, then blood leaks back into the left ventricle, called aortic valve regurgitation, or aortic insufficiency.
So here you go. So you have two conditions. That's all. Either being stenotic, being narrow, not opening properly, so you're not able to send the blood out. Or it's not closing properly. After you send the blood out from the heart, because the valve is not closing properly, you still have a space that the blood is going to sweep back, right? It's going to come back. That blood is destined to be going out. Now you are returning it back to the ventricles. And every time you do this, the amount of blood that's going to be returned to the ventricles is going to increase from every contraction, right? So these are the two conditions, either regurgitation or stenosis.
Usually, the aortic valve opens to about 3 to 4 centimeters squared, but with stenosis, it can become less than 1 centimeter squared. This is usually caused by mechanical stress over time, which damages endothelial cells around the valves. causing fibrosis and calcification, which hardens the valve and makes it more difficult to open completely. This type usually shows up in late adulthood, with patients over 60 years old. Similarly, patients that have a bicuspid valve with 2 leaflets as opposed to a tricuspid with 3 are more at risk of fibrosis and calcification, since the mechanical stress that's usually distributed between 3 leaflets is now being split by 2 leaflets, and therefore they see more stress per leaflet.
This is rare. So the majority of the population, the valve has 3 cusps, right? But just stating the fact that some people who have this type of anomaly or congenital malformation of the valve, instead of having 3 leaflets, they happen to have 2 leaflets. Now the amount of stress that happening to 2 leaflets is going to be greater, of course, because the distribution was equal when you have 3, but now you end up having only 2 leaflets. So the amount of tear and wear is going to increase when you have 2 leaflets. But these are small number of people.
Another important cause of aortic stenosis is chronic rheumatic fever, which can cause repeated inflammation and repair, leading to fibrosis. In this case, the leaflets can actually fuse together, called commissural fusion, which is an important distinction from the type caused by mechanical stress over time.
So the majority of the cases, remember, talk about the stenosis, the majority of the cases are going to be tear and wear. And that's why in the beginning, and in your book, is saying 70 years or older, but here the dimension is 60. But it's just an arbitrary number. So an elderly person, that valve is being working for the last 70 years, right? So basically you have some sort of change to the morphology of the valve itself, the shape of it, the tear, like anything else in the body, right? So tear and wear is affecting it, okay? Now, the other cause, other than tear and wear, is going to be rheumatic fever. Rheumatic fever, why? Because rheumatic fever, you have a long standing, talking about 40 years of inflammation, right? And as a result, what is happening, that you have a fusion. Anytime you have inflammation is going to lead to fibrosis. That fibrosis is going to let the leaflets to fuse together. And that's what the commissural fusion is, right?
When the valve fuses together or hardens, it doesn't open as easily, right? And so as the left ventricle contracts, it creates this high pressure that eventually pushes on the valve until it finally snaps open, causing a characteristic ejection click. Since the blood has to flow through a narrow opening, there's turbulence, which creates noise or a murmur, which gets initially louder as more blood flows past the opening, and then quieter as the amount of blood flowing subsides, because less remains in the ventricle. This is called a crescendo-decrescendo murmur.
So this type of murmur is very characteristic, and I think you have a question there. Crescendo, decrescendo. Basically, it's going to be louder and it's going to fade away. Loud and fading away. Loud, fading away. Loud, fading away. That's called crescendo, decrescendo type of murmur. It's a systolic murmur. Again, why is it systolic? Because it's happening during ejection. And that's what systole. Systole is ejection. When you're ejecting the blood to the outside, because the blood is facing tremendous amount of difficulty passing through the valve, and you have that turbulence. First, you're going to hear the click, right? Because it's a fibrous connective tissue. It's going to click. It's going to drop open. You're going to have that click, and then you have the turbulence of the blood in the area because you have the stenosis, and that's going to lead to this very characteristic for aortic stenosis. It's a crescendo, decrescendo. And I have it in the slides for you as well.
Since now it's harder to open and push blood past this hardened valve, the left ventricle has to generate higher pressures each time it contracts to get the same amount of blood through. To accomplish this, the left ventricle can thicken its muscles, called concentric left ventricular hypertrophy. So basically, again, as we mentioned in the beginning, remember, every time you want to inject the blood, you are facing difficulty. So you have to push hard, and that's what's causing hypertrophy, left ventricular hypertrophy.
Don't worry too much about the type, but it's giving you the type. It's what is known as a concentric. Basically, you have to add more fibers. The ventricles adds more fiber. That's called concentric hypertrophy. But the fact is, what you need to remember, you are leading to hypertrophy of the left ventricle. And just by the hemodynamic of the fluid itself, it's very simple to understand. I'm sending the blood out, but I'm facing tremendous amount of resistance. Every time I try to eject, I have resistance. Eject, resistance. What I have to do, I have to multiply. I have to add more layers of the muscle to be able to squeeze most of the blood out. Okay?
This happens because new sarcomeres are added in parallel to existing ones.
The sarcomere is the unit of the muscle itself. Okay?
Even though you have this bulked up ventricle, the heart still might struggle to get enough blood through the narrowed opening and to the body, and ultimately to the vital organs. And that means that the person's at risk of developing heart failure and various symptoms related to whichever organ's involved. For example, if there's a reduction in blood flow to the brain, it could lead to syncope, and a reduction in blood flow through the coronary arteries to the heart's own myocardium could cause chest pain and angina. Patients might not initially experience symptoms at rest, only during exercise, because exercise requires more blood, right? And this heart isn't able to increase blood flow through the small opening.
So basically, yeah. So from here, all you have to remember, you have difficulty sending the blood out. Okay? So I'm supposed, as an organ, I'm supposed to get a portion of blood, and I'm not getting it. So where's my blood? Okay? I need oxygen. Depending on what organ we are talking about. If the heart is suffering, that's going to initially give you angina, and in severe form, it's going to be myocardial infarction. If it is the brain, for example, that's going to give you stroke, right? So the brain, or syncope, right? So basically fainting, all these signs and symptoms of a reduction of the blood supply to that particular organ, right? Depending on what organ. So this just give you an example. If it is the upper extremity, then you're going to have tremendous amount of hypoxia and hypoxemia in these organs, right? So basically, the organ that's supposed to receive the blood is suffering as a result of the stenosis that happening in the organ.
A final complication is called microangiopathic hemolytic anemia, which is essentially damage to red blood cells as they force through the smaller valve, splitting them into smaller fragments called schistocytes, leading to hemoglobinuria, which is hemoglobin in the urine. Treatment is usually a replacement of the valve, which often doesn't happen until after the onset of symptoms.
So the treatment for all this, like across the board, okay? If it is an advanced stenosis, regurgitation, it doesn't matter right side or left side, aorta or pulmonary, yeah? So treatment is mostly going to be the same. Most cases, particularly in severe cases, it's going to be valve replacement. And it's becoming, with the advancement in technology, right, and in medicine these days, it's becoming highly sophisticated. And usually, there is no complication for several years. People living their normal life for a good amount of time with these artificial valves.
All right, so that was aortic stenosis. What about aortic regurgitation? Well, normally, right after the ventricle pumps blood out through the aortic valve, the valve shuts and remains shut until the ventricle fills again. With aortic regurgitation, or sometimes aortic insufficiency, blood flows back from the aorta into the left ventricle during diastole, or during ventricular filling.
Again, remember why during diastole? Because during diastole, the pressure in the ventricles drop. You have low pressure, makes sense? And in the aorta, you still have high pressure, right? You just dump the blood outside, and the pressure in the aorta is somewhere around 100 millimeters of mercury, and the pressure in the ventricles drop close to zero. So what's going to happen? The blood is going to come back because of the elasticity of the aorta itself. It's a tube, right? And the amount of pressure you have in the aorta, it's a fluid. It's going to go back to the low pressure. Okay? That's what has been preventing. It's been prevented by the valves themselves. Okay, so the valve's holding the blood. No, you're not going back. But if it is insufficient, so some of the blood is going, as you can see in the arrow, some of the blood, because the valve's not closing.
About half of cases are
not closing properly, so the blood is leaking back into the ventricles.
or sometimes aortic insufficiency. Blood flows back from the aorta into the left ventricle during diastole or during ventricular filling. About half of cases are caused by aortic root dilation, which is where the root dilates or gets bigger, and in doing so pulls apart the leaflets, making it harder for the valves to fit snugly together and close all the way, and letting some blood flow backward. The vast majority, about 80%, of aortic root dilations are idiopathic, which means that the cause is unknown. The remaining 20% of causes are things like aortic dissection, aneurysms, or syphilis, all of which can ultimately lead to a widened aortic root.
So the majority of the cases, you're going to see, so you have root dilation, so somewhere around 50% of the cases, right? So 80% of that, what is causing the dilation? So 80% of the cases we can't pinpoint, and that's what idiopathic is unknown what is causing the dilation. But in a minority of the cases, like 20%, either you have aortic dissection or aneurysm of the aorta itself, or in some cases syphilis. Syphilis is not that, it used to be much seen in clinical settings, not that much these days. But these are basically the underlying pathophysiology of the dilation of the root. Basically, you have a tube this wide, and then all of a sudden it becomes this wide. Now, the valves don't follow with the widths. They are still the same length. And as a result, because the blood vessel expanded in width, the valve is no longer closing perfectly. You have a space left, which you see it pointed there.
Besides root dilation, regurgitation can also happen from valvular damage, from something like infective endocarditis, bacterial infection of the inner lining of the heart, or again from chronic rheumatic fever. In this situation, the chronic inflammation leads to fibrosis. Instead of fusing the valve leaflets together, it makes it so that they don't form a nice seal and instead let blood leak through. Patients with aortic regurgitation will have an early decrescendo diastolic murmur, caused by blood flowing back through the valve.
So now, again, I want you to be very clear on differentiating of the time of the murmur. Remember, with aortic stenosis, we are talking about systolic murmur. It's a systolic murmur because that's when you send the blood out, and that's when the blood is going to have the turbulence and having difficulty going back. Okay? Now, this murmur in this insufficiency or incompetency during diastole, because that's the time when the blood is going to go back because of the drop of the pressure. Okay? So don't confuse the two. So don't worry about the time for this one. The one that you have to remember is the crescendo decrescendo for the stenosis, for the aortic stenosis. This is known as early decrescendo.
Since blood's leaking back from the aorta into the left ventricle, the left ventricular blood volume increases, which increases the stroke volume, or the amount that the left ventricle pumps out during contraction, or systole. More blood pumped out of the heart per squeeze requires more pressure, so systolic blood pressure increases. During diastole, though, there's less blood volume in the aorta, since some of that has leaked back into the ventricle, which means that diastolic blood pressure decreases. A higher systolic pressure and lower diastolic pressure means an increase in pulse pressure, which is just systolic pressure minus diastolic pressure. A large pulse pressure, meaning a large difference between systolic and diastolic pressure, is referred to as a hyperdynamic circulation. Patients with a hyperdynamic circulation have bounding pulses, or water hammer pulses, because the blood, which is mostly composed of water, slams like a hammer against the walls of the artery with each heartbeat. These bounding pulses can be dramatic enough that they cause head bobbing that's in tune with the heartbeat, as well as causing the capillary beds in the fingernails to pulsate, sometimes called Quincke's sign. Over time, the increase in blood volume in the left ventricle causes the chamber to grow larger, called eccentric ventricular hypertrophy. In this situation, new sarcomeres are added in series to existing ones. Just like aortic stenosis, treatment for aortic regurgitation is replacement of the valve after symptoms in left ventricular dysfunction develops.
All right. Any questions? No? Okay. All right. So now we're going to do mitral. Now for mitral valve. All right. Again, for mitral valve, we're going to have the same thing. Either going to be a stenosis or regurgitation. Now, on mitral, what you're going to see is going to repeat over and over rheumatic diseases, right? So, rheumatic diseases is one of the leading causes of either insufficiency or stenosis when it comes to the mitral, okay? Because of the blood supply to the valve itself.
The mitral valve has two leaflets, the anterior and posterior leaflet. And together they separate the left atrium from the left ventricle. During systole, the valve closes, which means blood has just one option, to be ejected out the aortic valve and into circulation. If the mitral valve doesn't shut all the way, blood can leak back into the left atrium, called mitral valve regurgitation. During diastole, the mitral valve opens and lets blood fill into the ventricle. If the mitral valve doesn't open enough, it gets harder to fill the left ventricle, called mitral valve stenosis. Let's start with mitral valve regurgitation. The leading cause of mitral valve regurgitation, and the most common of all valvular conditions, is mitral valve prolapse. When the left ventricle contracts during systole, a ton of pressure is generated, so the blood can be pumped out the aortic valve. So a lot of pressure pushes on that closed mitral valve. But normally the papillary muscles and connective tissue called chordae tendineae, or heartstrings, keep the valve from prolapsing or falling back into the atrium. With mitral valve prolapse, the connective tissue of the leaflets and the surrounding tissue are weakened, called myxomatous degeneration. Why this happens isn't well understood, but it's sometimes associated with connective tissue disorders like Marfan syndrome and Ehlers-Danlos syndrome. Myxomatous degeneration results in a larger valve leaflet area and elongation of the chordae tendineae, which can sometimes rupture, something that typically happens to the ones in the posterior leaflet. That can allow the posterior leaflet to fold up into the left atrium. Patients with a mitral valve prolapse are usually asymptomatic, but often have a classic heart murmur, which includes a mid-systolic click, which is sometimes followed by systolic murmur. The click is a result of the leaflet folding into the atrium and being suddenly stopped by the chordae tendineae. Although mitral valve prolapse doesn't always cause mitral regurgitation, it oftentimes does. If the leaflets don't make a perfect seal, a little bit of blood leaks backward from the left ventricle into the left atrium and causes a murmur. The mitral valve prolapse murmur is somewhat unique in that when patients squat down, the click comes later and the murmur is shorter. But when they stand or do a Valsalva maneuver, the click comes sooner and the murmur lasts longer. The reason this happens is that squatting increases venous return, which fills the left ventricle with slightly more blood, and this means that the left ventricle gets just a little bit larger. The larger leaflets therefore have more space to hang out, and as the ventricle contracts and gets smaller, it takes just a little longer for the leaflet to get forced into the atrium. Standing, on the other hand, reduces venous return, meaning a little less blood in the ventricle, and so a little less room to hang out, and so the leaflet gets forced out earlier during contraction. The other heart murmur that follows this pattern is like the one in hypertrophic cardiomyopathy. So in addition to mitral valve prolapse, other causes of mitral regurgitation include damage to the papillary muscles from a heart attack. If these papillary muscles die, they can't anchor the chordae tendineae, which then allows the mitral valve to flop back and allow blood to go from the left ventricle to the left atrium. Also, left-sided heart failure that leads to ventricular dilation can lead to mitral regurgitation as well. Because as the left ventricle dilates, it stretches the mitral valve annulus, or ring, open and lets blood leak into the left atrium. Mitral regurgitation can also be caused by rheumatic fever, an inflammatory disease that can affect the heart tissue and lead to chronic rheumatic heart disease. The chronic inflammation leads to leaflet fibrosis, which makes it so that they don't form this nice seal and instead let blood leak through. Patients with mitral valve regurgitation typically have a hollow systolic murmur, meaning it lasts for the duration of systole. Now, even though we said that left-sided heart failure can cause mitral regurgitation, it also goes the other way. Mitral regurgitation can be a cause of left-sided heart failure. With mitral regurgitation, every time the left ventricle contracts, some blood is inadvertently pumped out into the left atrium, which leads to an increased preload as that blood is again drained back into the left ventricle after contraction. It's kind of like if you were digging a hole and every time you shoveled some dirt out, half of it would fall back in. It's lots of wasted work, right? In this way, both the left atrium and left ventricle experience volume overload. To better manage this larger volume, the left side of the heart undergoes eccentric hypertrophy, where new sarcomeres are added in series to existing ones, and so it grows larger. This compensation works for a while, but eventually the left ventricle might not be able to keep up, and it can lead to left-sided heart failure. Alright, now let's switch gears over to mitral valve stenosis, which is most often, again, caused by rheumatic fever. In this case, instead of having inflammation cause the leaflets to not form a good enough seal, the leaflets can actually fuse together, called commissural fusion. When this happens, the normal mitral valve opening, which is about 4 to 6 centimeters squared, can narrow down to 2 centimeters squared. This makes it a lot harder for blood to flow from the left atrium to the left ventricle, and so the volume of blood in the left atrium increases, leading to higher pressures in the left atrium. Higher pressures flowing through a fibrotic valve make a snap sound when it opens, which is followed by a diastolic rumble as blood is forced through the smaller opening. A constant elevation in both blood volume and pressure in the left atrium causes it to dilate and can allow blood to back up into the pulmonary circulation, causing pulmonary congestion and pulmonary edema, which can lead to symptoms like dyspnea or difficulty breathing.
So remember, when you have a stenosis, so in a normal condition, what you are doing, the blood is coming through two from each side. This is what we have pulmonary veins, right side and left side. You have two veins bringing the blood from the lungs. You're filling in the atrium right there. Okay? However, you're sending the blood here, but this valve is not opening properly because it's a stenotic. Okay? What's going to do is you have a backup of the blood in the lungs. And that's when you're going to have pulmonary hypertension, pulmonary congestion in there, and edema as a result, the rest of the world. Because if the lungs are filled with fluid, you don't allow for enough time or enough space for air. Because remember, when we talked about ventilation, perfusion, match. It's always going to have ventilation and perfusion, right? But if you are just filling the entire two lungs with blood, you don't allow for enough space for the lungs to expand. Okay? And that's why they have difficulty breathing, which is the dyspnea, right? Now, eventually what's going to happen, you're going to have hypertension, you're going to have pulmonary hypertension. That pulmonary hypertension is going to lead to the right side of the heart now, okay? Because remember, the blood is going, imagine there is a line from here out, right? So a line from here. So you're sending the blood from the right ventricle to the lungs. You get oxygenated and then it comes back. So if the lungs are not emptying properly in enough time for the blood to be sent from here, not only are you going to have hypertrophy of the right atrium, you end up having hypertrophy in the right, in the left atrium. You're going to end up having hypertrophy in the right ventricle as well, because you are not allowing for the blood to leave the right ventricle to fill the lungs. But the lungs are occupied by the portion of the blood in the previous contraction. Make sense? So that's what's going to happen eventually. Okay?
All this extra blood volume in the pulmonary circulation causes higher pressures in the pulmonary circulation, or pulmonary hypertension, which can ultimately make it harder for the right ventricle to pump blood to the lungs. And over time, the right ventricle can hypertrophy and ultimately fail, which is called right-sided heart failure. In addition, when the left atrium dilates, the muscle walls stretch, and the pacemaker cells that run through the walls become more irritable, increasing the risk of atrial fibrillation. During atrial fibrillation, the right and left atrium don't contract properly anymore, which allows more blood to stagnate. Since the left atrium is already pretty dilated, static pools of blood can become a major risk for thrombus formation. And if a blood clot forms, it can immediately get into the systemic circulation. Finally, thinking about the heart in relation to other structures in the chest, if the atrium dilates and gets really large, it can compress its neighbor, the esophagus. And patients might have difficulty swallowing solid foods, called dysphagia. For patients with severe problems related to mitral regurgitation or stenosis, treatment involves valve repair or surgical replacement of the valve.
Yeah, so the treatment.
Thanks for watching. You can help support us by donating on Patreon or.
So either stenosis or insufficiency, the treatment is going to be the same in most cases. Particularly in severe cases, it's a valve replacement. So that's it for all the valvular disease. If you have any questions, still not very clear on what's happening in what condition, let me know. We can sit down again and figure it out. Okay? But all the details are in the slides, of course. Now tomorrow we'll go up. So remember, we're going back. So tomorrow we'll do angina, we call it infarction, hypertension. Okay? So that will put us back to the So, and we still have another week. We still have week 10 to get all the way up to where we started from week 1. Okay? Yeah. Questions? Yeah. All right. I'll see some of you.